Okay, let's review the pituitary gland and the hormones that it's regulating so we can connect the two together when we talk about the disorders. Remember, hypothalamus is the one that controls the release of hormones from other glands, such as your pituitary gland. For example, pituitary gland has two lobes. You have the anterior lobe and you have the posterior lobe. Okay. Now, if you recall, between these two lobes, your anterior is the one that's responsible for the regulation of multiple hormones, like your growth hormones, your GH, your ACTH or the adrenocorticotropic hormone, TSH, which is the thyroid stimulating hormone, FSH is the follicle stimulating hormone, LH, which is luteinizing, and then you have your prolactin and the melanocyte, which is your MSH. Then the posterior lobe is the one that actually regulates or controls the secretion of the ADH, which is the antidiuretic hormone, and the oxytocin. Okay, and in the previous chapter, we kind of touched base on what they do, what are the functions of, for example, your growth hormone, your ACTH, your TSH, FSH, LH, prolactin, and MSH. Okay, but let's review it. Okay, so let's focus on anterior lobe first. I need this space, so let's take it out. Okay, so let's start with the growth hormone, right? We did talk about the growth hormone, and we said, oh, the growth hormone is responsible for the growth of the bones, tissues, and also responsible for the mobilization of stored fat for energy. Okay, but let's remember that your growth hormone is the one that's actually responsible for the growth of the bones and the tissue. Okay, we'll talk about this order later on that affects this growth hormone. ACTH is the one that talks to your adrenal glands. Remember the cortex and the medulla, right? For the ACTH, this one is the one that's responsible for the release of the cortisol, which is an anti-inflammatory and stress response, and also your aldosterone, which is the one that is actually regulating the reabsorption of the sodium and excretion of potassium, right? And water. TSH is the one that talks to your thyroid. That's why it's called thyroid stimulating hormone. In the thyroid, there is T3, T4, and the calcitonin. Right? T3 and T4 responsible for metabolism. Your calcitonin responsible for the calcium regulation. Follicle stimulating hormone is responsible for the development of the eggs in the ovaries. Follicle stimulating hormone is the one that's responsible for development of eggs and the maturation of eggs in the ovaries, and also is responsible for estrogen production, and that's for female. And then for male is the one that's responsible for sperm production, right? For male. The luteinizing hormone is the one that is actually responsible for the egg release, right? When those eggs from the ovaries is being released, the ovulation, luteinizing hormone is the one that's responsible for that, and that's for female. And for male, it's responsible also for, for female. Let's go back. Okay. Luteinizing hormone is responsible for the egg release for female and the production of progesterone, right? This is for female still. Okay. Now for male, responsible for testicular growth and the testosterone. Okay, this is for male. Okay, prolactin stimulates breast milk production. Breast milk production. And the melanocyte is the pigmentation of skin. That's why it's called melanocyte. All right, now there you go. That's the overview of the anterior pituitary and the hormones that it's regulating and the function of those hormones. So we need to remember them so that when we talk about the disorders later on, it's very easy to understand. Connect the two dots together and it's gonna make sense. Okay. So now we have hyperpituitarism. From the word hyper, right? Hyperpituitarism. So now you would know that, oh, this is the overproduction of those pituitary gland hormones, or the overexcitation of those pituitary glands, right? This is a pathologic state that is caused by the excess production, like we said, excess production of one or more of that anterior pituitary hormones that we just talked about. Most common cause is the presence of tumors. Okay. Most common first symptoms, though, that you will see in patients that have hyperpituitarism would be visual deficits and headaches. Now let's talk about growth hormone. We did learn some of the function of the growth hormone, and we already know that it's responsible for the growth of bones, tissues, and mobilization of fat for energy. Okay, those are some of the functions of the growth hormones. So remember, we're still hyperpituitarism. There's an excess of these growth hormones. So you have two types. You have gigantism. Oops, wrong one. You have gigantism and you have acromegaly. Okay, what's the difference between the two? It varies depending on when it actually happened in the life stage of a person. Your gigantism usually happens or occurs in early childhood or puberty when the long bones is still growing. So you remember that you have your diaphysis, right? That's a long bone. The middle is the diaphysis, and then in here would be what we call your epiphysis, right? And then we call this one epiphyseal plate. And this is the area where it's still open, right? In the time that the person still had not reached puberty or early adulthood, this remains open and it's not sealed yet. So when there's an excess growth hormone, gigantism happens. So the person will actually keep growing and growing in a longitudinal uh, plane, and up to sometimes the patient would even grow up to 8 feet because of the excess growth hormones. However, because of all these growth hormones that is going on or being secreted in the body, the patient actually has a lot of health problems too. Same thing with the acromegaly. The difference is that in acromegaly, this epiphyseal plate have already closed. Okay, this one already closed. Acromegaly usually happens or occurs after that epiphyseal plate had already closed, usually in the fourth and fifth decade of life. So let's make sense of it. If the epiphyseal plate had already closed and there's an excess growth hormone, right? This is already closed right here. And there's an excess growth hormones. So what's going to happen? There's no way that that bone is going to grow in the longitudinal plane. Instead, the bone is going to increase in thickness, right? It's going to have increase in thickness and width, okay? Because it's not going longitudinal anymore, it's gonna go this way. So now you're gonna see weird or different physical features right here. That's why they have enlargement and deformities because of this reason. In addition to that, remember that your growth hormone is responsible for growth of bones and tissues too. So they're gonna have enlarged tissues. They're gonna have enlarged of the tongue, skin, liver, spleen, even larynx. So those people that have this condition, you will hear that they will have deep voice because of the enlargement of the tissues in the throat. And they will even have dysphagia, which is the difficulty swallowing because of the enlarged tissues in the throat. All right, and then again, mobilization of fat. That's one function of the growth hormones, right? So you're gonna see patient will have increased free fatty acids in the bloodstream, and it makes sense because we did say that growth hormone is responsible for mobilization of those fat for energy. However, because of that, we're gonna have some problem with atherosclerosis, right? Blocking those blood vessels with those fatty acids, and then you might even have a coronary artery disease. Patient can even have those coronary blood vessels blocked. All right, this right here I have not mentioned yet, but one um, function of or additional function of growth hormone is that it antagonizes the effects of insulin. So if it antagonizes the effects of insulin, what's going to happen to the body? Blood sugar will not be able, or blood glucose will not be able to be controlled, right? Again, you have an excess growth hormone, and one of the functions is it antagonizes the effects of the insulin. So your patient is going to have hyperglycemia or even diabetes mellitus because of this reason. Okay, increased prolactin. We already know the function of, or some of the function of prolactin is that it is responsible for breast milk production, right? Okay, so if you have hyperpituitarism, which is excess of this hormone, which is your prolactin, you're going to have what we call hyperprolactinemia, which is increased prolactin in the blood. Now, we just talked about prolactin is responsible for breast milk production. Your patient is now going to have what we call galactorrhea. And what is galactorrhea? Galactorrhea is the discharge of breast milk from the breast, even though the person is not pregnant or did not just give birth, but that's happening because of the increased prolactin in the blood. Okay? All right, let's talk about this really quick. So, one function of prolactin that I would like for you to add in your notes is that it inhibits the release of what we call gonadotropin releasing hormone. And what is this? Well, this GnRH or gonadotropin releasing hormone is coming from the hypothalamus. Okay, hypothalamus, that part of the brain before the pituitary gland. Gonads, by the way, is something to do with like sex hormones, your luteinizing hormone, your FSH, your testosterone, those sex hormones. This GnRH is a hormone that the hypothalamus is actually controlling. What it does is that's why it's called gonadotropin releasing hormone, to release that hormone, right? Usually, the gonadotropin releasing hormone is telling the pituitary gland to secrete the FSH and the LH. Okay, now without that, because we said prolactin, right, is inhibiting, meaning it's stopping or slowing down the release of the gonadotropin releasing hormone. So if you have an increased prolactin, there will be an increased stopping of this gonadotropin hormone. There will be an increased inhibition of this hormone. If there is an increased release of this hormone, then your pituitary is now going to decrease the release of their sex hormones, the FSH and the LSH. Next thing you know, the patient is going to have what we call hypogonadism. Okay? And what is hypogonadism? It is the failure of those sex hormones or sex glands to function properly. Failure of the sex glands to function properly. And that makes sense, right? Because your FSH and your LH right here, right, are the ones that actually we did mention that they are actually helping with the production of the testosterone for men. If there is a decrease of these things, there's a decrease of your testosterone, then you're going to have failure of your sex glands to function properly. Okay, TSH or increased thyroid stimulating hormone, we already know that thyroid stimulating hormone is the one that stimulates the thyroid to actually secrete T3 and T4, which are both responsible for the metabolism of the body, and then the hormone calcitonin, which is the one that's regulating the calcium. Okay. In the next chapter, we'll talk about those thyroid disorders and parathyroid disorders. So we'll keep that as like that for now. Just know that or remember that hyperpituitarism can cause increased TSH, which is hyperthyroidism. Okay? And then also ACTH. So ACTH, your adrenocorticotropic hormone, okay, is the one that is actually going to the adrenal gland. Remember, adrenal cortex, and the one that is actually responsible for the cortisol and those glucocorticoids. Okay, and also the increased aldosterone, Right, so all of those will be increased because of the increased ACTH. Okay, but we will elaborate this later on in the chapter, but for now, know that ACTH or increased ACTH will cause that increase um, function of the adrenal gland or secretion of the adrenal gland hormone, increase of this cortisol and the aldosterone. Okay, let's look at the features of this acromegaly that we're talking about earlier on when we're talking about growth hormone. So go to page 931 and you will see the progression of the acromegaly in a person, in the same person over the course of her lifetime. You see how it starts as, her bone formation is still okay and normal up until, later in the stage of her life, and that's when it becomes an acromegaly, where you could see that the bone has some kind of deformities because of the excess growth hormone. So diagnosis for hyperpituitarism, it really is going to be depending on the physical assessment of the patient. You're going to see, like we said, if you have patients like the acromegaly that we just saw, you're gonna see it right in a physical assessment. In addition to that, what you're gonna do is you're gonna order some imaging, and we did talk about like the bone will be thickened, thickened, and it will increase in width. So you're gonna see it when you order those imaging studies, like your CT scan, your MRI, and then we're gonna do some laboratory studies, and we just talked about that it's an increase of those hormone level in the blood, right? So when you do those lab studies, you're gonna see that those hormone is actually elevated in the blood, and it will tell you, or it will, suggest that the patient actually has a hyperpituitarism. Okay, medical treatment. Like we did say earlier on, the most common cause of hyperpituitarism is tumor. Okay, tumor in the pituitary. So what we're gonna do is what we call hypophyseectomy, or the removal of that adenoma, or even the pituitary itself. Okay, if you can see that page, that figure 48.2 in page 931, that's a very cool diagram or picture, and it's showing us the what we call transsphenoidal surgical approach to reach the pituitary gland. You see how it goes through the nose and it tries to reach the pituitary gland from there, and that's what they use, and what we call it hypophyseectomy. We remove those, maybe the adenoma, or remove the pituitary itself. All right, and then patient is gonna have some radiation if needed, and then patient is now going to have a drug therapy, because remember, the pituitary is responsible for a lot of hormones. So if you remove it, then you're going to have to replace the hormones that the pituitary is secreting, right? So your patient is going to have a lifelong replacement of the hormones. Okay, nursing care, altered body image. We did say there's going to be like those um, deformities of the bones, gigantism, even, right? When they grow really, really tall. And then they will have reduced activity tolerance because their body cannot take it, because it's not in the normal state, right? And there's also, in addition to that, we'll have multiple health problems. They will have pain from those big bones, or from the height itself, right? And then post-operative care for hypophyseectomy is in page 934. Please read them. Just like in any other just like in any other surgery that the patient goes through, we have to remember that we are actually monitoring them post-operative. So let's look at that page 934. It tells us that if the anterior pituitary is removed, you will need hormone replacements for the rest of your life. For 3 months, or as advised by the physician, avoid any activities that cause straining, heavy lifting, and bending from the waist. Straining increases in intracranial pressure, so make sure that we're preventing the increased intracranial pressure. One reason could be constipation after the operation, so we make sure that we prevent constipation. And then numbness of the incision area and decreased sense of smell are temporary, so you got to educate your patient. Follow-up care is essential to monitor for any signs of tumor recurrence. Okay, it means after the patient had that surgery, it's very, very important for us to make sure that there's a follow-up care, there's a follow-up appointment. Because what we don't want is we did, we the patient went through all of those treatment, and then what we're now monitoring is the recurrence of the tumor. Okay, hypopituitarism is the inadequate secretion of pituitary hormones. Now, it's the opposite. We did talk about hyperpituitarism, where there's an excess secretion of those pituitary hormones. Now we have hypopituitarism, which is inadequate secretion. There's not enough of those pituitary hormones, or very small of those pituitary hormones. The manifestations will depend on the stage of life when the deficiency occurs, just like your gigantism and your acromegaly. First one is the growth hormone. When there is an inadequate secretion of the growth hormone, the one that is actually helping for the growth of the bones and then the tissues, then you're gonna have what we call dwarfism. Okay, it may be by genes, hereditary, or secondary to the damage to the anterior pituitary gland during pre-adolescence. Okay, and also we have what we call panhypopituitarism. This is caused by pathologic process, so you're gonna have hypotension. Some causes could be hypotension during postpartums, tumors again, chronic infection, destruction or removal of the pituitary. Because if you remove it, of course, the growth hormone is not gonna be there. Suppression of the pituitary hormone. Panhypopituitarism is also called as the thymus cachexia, and this is when there's a muscle or organ wasting because of the absence of the growth hormone. There will also be disruption of the GI and the metabolism itself. Okay, hypopituitarism. Again, we will save that thyroid conditions later on in the next chapter, but decreased TSH will mean decreased thyroid hormones, what we call hypothyroidism. All right, and then you have the ACTH. Again, if there's a decreased ACTH or adrenocorticotropin hormone, there's going to be a decrease of that cortisol that we did talk about, which is actually helping us to fight for inflammatory and stress. So that means the patient is going to have a decreased ability to fight stress because of that decreased ACTH and decreased cortisol. MSH is the pigmentation of the skin, so that when there's a decreased MSH or hypopituitarism, the skin will be pale. There will be a skin pallor. Then you have the decrease of the LSH and the FSH, which is again our gonads or our sex hormones. If there's a decrease of this LSH and SH, then we're going to have decreased libido, right? Decrease of those libido, decrease of those secondary sexual characteristics. Your body hair, sexual function, function is going to be decreased, or there's going to be a sexual dysfunction because of the decreased secretion of the LH and the FSH. In general, when you have hypopituitarism or your pituitary is not secreting enough of the hormones that is supposed to secrete, you're going to have a fatigue, weakness, malaise, cold intolerance, and lethargy. So diagnosis is just the same as the hyperpituitarism. We're gonna check the imaging, we're gonna do the labs to see the levels of the hormones in the blood. And of course, with hypopituitarism, then the level will be low. Medical treatment, we have to replace those hormones, okay? We have to replace those deficient hormones because we need it, the body needs it. Thyroid stimulating hormone or your hypothyroidism is going to need what we call your thyroid hormone replacement, your levothyroxine, the medication. And then gonadotropin needs your estrogen and your testosterone, right, to replace because there's not enough of the FSH and the LH. Growth hormone can be replaced also if it is actually still in the stage where we can give it to the patient. So yes, it's available, growth hormone replacement. Nursing care is the same as your hyper. There's going to be an altered body image, changes in the body temperature, libido changes, and then education about those medication or hormone replacement or hormone medication that we're going to give to the patient. But remember that these are hormones that you're replacing. Okay, hormone has a lot of function in the body. Hormones has a lot of effects in whatever target organs it is. So when you're giving hormones, you're gonna make sure that you're monitoring that you're not actually, over exciting the target organs or giving them too much of the hormones, because those hormones that we're replacing, if it's given a lot also or in excess, is not also healthy for the patient. Posterior pituitary disorders, this is now the disorder when there's a problem in the posterior pituitary, right? Your antidiuretic hormone, what are those two hormones that the posterior pituitary secrete? Is the ADH, right? And the oxytocin. Okay. Um, but we will focus more on this. So you have your diabetes insipidus and you have your syndrome of inappropriate antidiuretic hormone. Diabetes insipidus is different than diabetes mellitus, okay? Diabetes insipidus is characterized by excessive output of diluted urine. Okay? Excessive output of diluted urine, meaning there's a lot of those diluted urine that is coming out. Okay, there's three types. There's nephrogenic, neurogenic, and dipsogenic, which is from psychiatric conditions. But let's look at these two right here because we need to know them. Nephrogenic, neurogenic, dipsogenic, or what we call polydipsia. Nephrogenic is inherited. Some cases are caused though by some medications like the lithium carbonate, and this medication diclomycin can cause nephrogenic. Neurogenic is usually from tumors, trauma, infections, and surgery, and can also be triggered by CVA aneurysm or of intracranial hemorrhage. So what's the difference between the two? So let's look at it. So the whole thing starts in the hypothalamus, right? Now from the hypothalamus, it's gonna tell the posterior pituitary gland to actually secrete the what we call ADH, right? Antidiuretic hormone. This ADH is going to go to the kidneys, right? The effects of this ADH is to maintain fluid balance, and what it's doing is it's asking the kidney to reabsorb the water, reabsorb the water, reabsorb water in the renal tubules. That's why it's called antidiuretic hormone, right? Because of that, because of the reabsorption of water in the renal tubules is increased, then you're gonna have decreased urine output. Okay? Now, let's talk about the neurogenic and the neurogenic DI or diabetes insipidus and nephrogenic DI. Neurogenic DI is happening when there's a problem here, around here in this area, in the hypothalamus. That's why it's called neuro, right? It could result from some hypothalamic tumors, maybe head trauma or infection, some surgical procedures, some metastatic tumors that actually reach the hypothalamus, or some aneurysm or intracranial hemorrhage. So for your neurogenic DI, it's happening here. Okay, with the hypothalamus and the posterior pituitary gland and the secretion of the ADH, right? This is where it's stopping. So if there's a decrease of ADH secretion in here because of neurogenic DI, it's gonna cause your increased urine output, right? Remember the reverse of that, okay? Same thing with your nephrogenic DI. The only difference is that in nephrogenic DI, everything else here, right? Everything else in the hypothalamus, in the posterior pituitary gland, the release of the antidiuretic hormone, there's no problem in there. Everything is okay. The problem is in the kidneys. The renal tubules of the kidneys is not responding to the release of the ADH. That is what's going on with the nephrogenic DI. Okay, the kidney is the one that has a defect. The renal tubules is not responding to the ADH. Because of this, same thing. You're going to have an increase in the urine output. Okay, signs and symptoms of the diabetes insipidus. Well, you're gonna have massive diuresis, right? I just said it. There's going to be an increase of the urine output because there's nothing that's stopping it. The antidiuretic hormone is not doing what it's supposed to be doing. So now you're gonna have increased urine output, massive diuresis. And because of that, your patient is gonna have increased thirst because they're gonna keep peeing and peeing. Now they're gonna have to replace the fluid that is being lost, so they're going to be thirsty. Because of that too, your patient is at risk for dehydration, right? In addition to that, your patient is going to have malaise, lethargy, irritability, and irregular heartbeat because of all those fluid imbalances going on in the body. Okay, medical diagnosis from health history, physical examination, and laboratory findings. We're gonna do the 24-hour urine collection. Oops, 24-hour urine collection. And you're gonna see there's a massive urine output, right? Because of this increased dilution of the urine, you're going to have what we call low urine specific gravity or low urine osmolality. The dilution of the urine is going to be increased. So you're going to have those increased 24-hour urine collection and then low urine specific gravity and low urine osmolality. How do we treat diabetes insipidus? Well, we would have to know what is causing it, right? For your neurogenic DI that we just talked about, we can actually give this medication desmopressin acetate, which can be given orally, intravenously, or by nasal inhalation. And this is actually a replacement of the hormone that is missing, the ADH. And then we can have ADH replacement with psychotherapy, right? For your dipsogenic DI, those patients that is actually just keep drinking and drinking and drinking and peeing and peeing and peeing, that's what we call dipsogenic DI, and it has something to do with psych. So you're gonna give the hormone replacement plus psychotherapy. Nephrogenic DI, where the problem is in the kidneys, right? What we do is we're going to do sodium restrictions and thiazide diuretics. And this is what's going on, why you want to restrict sodium. So if there's a decreased sodium in the body, the filtration rate is going to load also when it gets to the kidney, right? So then that means less sodium will also be filtered in the kidney. And when that happens, remember this, where sodium goes, water follows, right? So if there's less that's being filtered in the kidney and reabsorbed by the kidney, then that means that there's going to be a water reabsorption in the proximal tubules, right? So it will be an increased water reabsorption. Okay, it's like going back to the body. Now, because of that, you're going to be a decreased urine output, which is what we want when you have the diabetes insipidus, because that is the opposite of that. Okay, now you're probably asking, well, there's an increased urinary output. Why am I giving a diuretics? Well, it's a thiazide diuretics, okay? It's not those Lasix or the furosemide that is actually secreting those electrolytes and the water. What thiazide diuretic do is that it decreases the urinary volume by reducing flow to the distal pheron, to the distal distal nephron of the kidney. And what it does is same thing as the other one. If there's a reduced flow to that distal nephron of the kidney, there's going to be a decreased filtration also. And when there's a decreased filtration, again, same thing. Where sodium goes, water follows, right? So now you're going to have a increased water reabsorption, which can cause a decreased urine output, which is what we want. Okay, so again, medical treatment for diabetes insipidus is based on the cause. Syndrome of inappropriate antidiuretic hormone, or SIADH, is when there is an elevated ADH. Okay? When there's an elevated antidiuretic hormone, what's happening is that the kidney is retaining water. Okay? Kidney is retaining water. Next thing you know, there will be a decreased urine output. Right? Because of the elevated antidiuretic hormone. The urine that's coming out is going to be decreased. Okay? But because of this, there will be a water intoxication. The, the body will have that water intoxication. Okay? And when there's a lot of water in the body, sodium is going to be diluted. Right? Now, what could cause the syndrome of inappropriate antidiuretic hormone? There will be causes: trauma, infection, surgery, tumors, medications, some diseases, and some cancers can cause this. What are signs and symptoms of the SIADH? There will be, like we said, water retention. There will be a delusional hyponatremia. When there's increased water in the body because of the decreased urine output, the sodium in the body is going to be diluted. So what we call delusional hyponatremia, right? Because it's diluted, then that means it's decreasing. There will be weakness, muscle cramps, twitching, anorexia, nausea, diarrhea, irritability, headache, weight gain without edema, and then level of consciousness will deteriorate, seizure or coma. If you can remember, these are your signs and symptoms of your hyponatremia. Right? And it makes sense. You're retaining all those water, you're diluting the sodium in your body. Now you're going to have all of these signs and symptoms that actually mimics hyponatremia. Medical diagnosis will do lab tests, your serum and urine osmolality, because you want to see how diluted the urine is. And then for labs, of course, you want to monitor your sodium and some electrolyte imbalances. For medical treatment, we gotta correct the cause, right? And what we want is to promote elimination of that excess water, stop that water intoxication that's happening. And in addition to that, we are going to give them this hypertonic IV fluids, right? If you give them hypertonic IV fluids, very slowly though, over the course of 4 to 6 hours period, what it does is it's actually promoting the elimination of the excess water from the body. We're going to do fluid restriction, which is only 800 to 1000 ml per day, and increase the sodium intake. Like we said, the sodium will be diluted and it will be low, so you want to increase the sodium intake. We give them diuretic only if the sodium level is at least 125 ml. And why is that? Because when you're giving diuretics, those electrolytes are actually coming out of the body as well, and you don't want the sodium to go low. Remember, if the sodium is too low, you're putting the patient at risk for seizure and then coma, even death. Okay, so diuretic only if the sodium level is at least 125 MEq per liters. We can also give these medications, lithium and or dimethyl, and what it does is it's blocking the effects of the ADH on the kidneys. Okay, so it could help with this situation. However, please remember your lithium has a lot of side effects and also has a very narrow therapeutic and narrow toxicity range. So we got to be careful with using those medications as well. And then you can give your Vaptans, your tolvaptan, lixivaptan, satavaptan, or conivaptan. This one promotes water elimination while conserving sodium. So the goal here, if you can see right here, right, the goal is to increase the water elimination from the body, right? And to also increase the sodium level in the blood. Nursing care is seizure precaution. And why is that? Please remember, when sodium is very low, right? When the sodium becomes really low, patient will go into seizure, patient can go into coma, and even death. Right? So we are actually making sure that we're doing some monitoring to make sure that the patient, if they do have the seizure, is not going to injure themselves. Elevate head of the bed no more than 10 degrees to improve the blood flow to the heart and reduces the release of ADH, because if the heart has a low blood flow, it is actually telling the body to actually release the ADH, because the heart is like telling them, oh, I have a less blood flow here. I need to actually retain water. So ADH, I need you to be released so that you can actually retain water. And it's not good, right, for this situation. So you got to make sure that the head of the bed is no more than 10 degrees to make sure that there's a blood flow to the heart. Encourage fluid restrictions because of the water intoxication, and then drug regimen and adherence, making sure that the patient is actually following or compliant with the medication regimen. Okay, now let's talk about the adrenal glands, disorders of the adrenal glands. I did tell you earlier the Cushing syndrome, and we will elaborate more on that. So you have your Addison's disease and you have your Cushing syndrome. Addison's disease is when there is a hypofunction of the adrenal gland, right? Hypofunction meaning it's not functioning, it's functioning less than it should be, right? This Addison disease is a destructive disease process affecting the adrenal glands. Because the adrenal glands is affected, there will be a deficiency of the cortisol and the aldosterone. We've been talking about this. Your ACTH hormone, right? The adrenocorticotropic hormone goes to the adrenal gland, and if the adrenal gland is going to secrete cortisol and aldosterone. Okay, causes, there will be primary, which is autoimmune, usually your idiopathic atrophy, like when your own immune system is actually, out of whack and it's not functioning how it should be. It will be primary, or what we call autoimmune, and it's attacking the adrenal glands. You can have a secondary cause, which is possibly damage from the hypothalamus or the pituitary. And why is that relevant? Remember, where's your ACTH coming from? ACTH, right? Adrenocorticotropic releasing hormone, or adrenocorticotropic hormone, is now being released to go to the adrenal glands, right? And if there's a damage to this, right, then you're not going to have this. Then your adrenal glands is not going to secrete what it's supposed to secrete, which is the cortisol and the aldosterone. Signs and symptoms. Okay, let's start with our drawing earlier on. So, ACTH, oops, okay, ACTH, pituitary gland is telling the adrenal glands to now secrete my cortisol, and the aldosterone, and the cortisol is actually an anti-inflammatory and stress response, right? And in addition to that, actually is helping me or helping the body to increase gluconeogenesis, which is increasing the glucose because you need it for stress, right? Um, and then for the aldosterone, this is responsible for reabsorption of potassium and increase the excretion of potassium. So aldosterone is the reabsorption of sodium plus increased excretion of potassium. Okay. All right. Let's make sense of these signs and symptoms. So you have, we said there's a hypoglycemia because of the impaired secretion of the cortisol. Well, you have an Addison's disease, right? Addison's disease is a deficiency of the adrenal glands, right? This adrenal glands is not functioning properly, or it's not um, handling the secretion of the hormones that it's supposed to handle. Um, so now you have a hypoglycemia because you have an ACTH, the adrenal glands is in here. However, it's not actually secreting those cortisol, right? Properly. Cortisol is the responsible for the increasing of glucose and increased gluconeogenesis. So if you don't have that, you're gonna have low gluconeogenesis, hypoglycemia. Okay? Hyperkalemia is because, let's go back, ACTH, adrenal glands. Now I don't have this aldosterone. The aldosterone, you're telling me, is the reabsorption of sodium and increased excretion of potassium. But I don't have this. So now I'm going to have decreased potassium excretion. Potassium is going to stay. Now you're going to have hyperkalemia, right? And then you have hypovolemia and hyponatremia. ACTH, adrenal glands, now it's going to go to the aldosterone. The aldosterone is telling me that's a reabsorption of sodium and increased excretion of potassium, but I don't have this. So now there's no reabsorption of sodium. It's going to be accelerated sodium and water excretion. Makes sense, right? All right, and then other signs and symptoms will be weakness, lethargic, unexplained abdominal pain, and malaise. The way I remember this, Addison, right? Addison is is a deficiency of the adrenal gland or hypofunction of the adrenal gland. So I need to add, right? I need to add because there's not enough of this function of the adrenal gland. Okay, there's one thing we need to remember for the Addison's disease. There is what we call Addisonian crisis right here. Okay, it's an acute adrenal crisis and it's life-threatening emergency. Okay, what's happening is there's going to be a sudden decrease of those available adrenal hormone, and sudden is never good, right? Sudden decrease of available adrenal hormones. So everything all of a sudden is going down, right? What are the triggers? What could cause this? One of them is adrenal surgery. Maybe there's a surgery and the adrenal gland is actually, you know, accidentally damaged, and then maybe a pituitary destruction too. That could also cause this dysonian crisis. Abrupt withdrawal of the steroid therapy and stress could cause this. Maybe infection, trauma, illness, emotional, or psychiatric disturbances. Okay, then because of this sudden decrease of the available adrenal hormones, we're going to have some signs and symptoms, right? Because those adrenal hormones are responsible for some bodily functions and the electrolyte balance, right? So you're going to have signs and symptoms of hypotension, tachycardia, dehydration, confusion, hyponatremia, hyperkalemia, hypercalcemia, and hypoglycemia. All right, let's go to page 941, the table 48.1. Very important for us to know. When there is an acute adrenal crisis or Addisonian crisis that's happening to our patient, we really need to know what we're going to do, what is the intervention that I'm supposed to do as a nurse. Number one is blood sample will be collected to determine plasma cortisol level. You want to make sure, or you want to see the cortisol level, see what's going on in the adrenal glands, right? The hormone that is actually being released by the adrenal gland. The rationale of this is to establish a baseline and obtain data to guide treatment. Then we're going to give, or we're going to do an IV infusion of normal saline with 5% dextrose, and the reason is to provide access for administration of fluids and drugs. Then we're going to give the initial dose of hydrocortisone, because what we did say is a sudden decrease of the adrenal hormone, so you want to actually replace it. So we're going to give initial dose of hydrocortisone. It's an IV push followed by infusion of saline and dextrose over the next 8 hours. Rationale is to provide a loading dose and maintenance infusion. Then we're going to do additional doses of hydrocortisone per infusion at a rate of 100 milligrams every 8 hours. And the reason for this is to ensure continuous source of the glucocorticoids. Okay. Cushing syndrome is the overproduction of the adrenocortical hormones, right? Now, this is overproduction. I don't need to add like the Addisonian, right? This one is Cushing, is an overproduction. What is causing this? It could cause by adrenal tumors or a prolonged administration of those high doses of those corticosteroids, those hormones that the adrenal gland is actually producing and secreting. Okay, Cushing syndrome is the hypersecretion of the adrenal cortex that may result in the production of excess amount of the glucocorticoids, right? That's why we call it Cushing syndrome. The hallmark of the Cushing is in page 944, and we need to remember the signs and symptoms of our Cushing syndrome. Clinical manifestations of a patient with this disorder has a facial redness, truncal obesity. In page 944, truncal obesity. You could see that picture in figure 48.3, the trunk, right? There's an excess adipose in the body trunk. There's protein wasting. The extremities are thin and friable, and there's slender extremities. Okay, so you see the truncal obesity, and then protein wasting. The extremities are actually slender and thin, and then there will be facial fullness, or what we call moon phase. Moon phase, okay? And then they're gonna have purple striae on the abdomen, the breast, the buttocks or thighs, and the patient will have osteoporosis and hypokalemia of uncertain cause. Okay, we need to know this and highlight these signs and symptoms or clinical manifestations of Cushing syndrome. In addition to that, there will be hirsutism, menstrual disorders, hypertension, delayed wound healing, insomnia, irrational behavior, and mood disturbances. Okay, how do we diagnose? Where we do the 24-hour urine test again to see the cortisol, right? Cortisol level, and then some radiologic studies. What you want to see is what's going on in the adrenal glands. Is there any tumor there that is actually causing this hypersecretion? Medical treatment, we want to actually decrease that ACTH or decrease that adrenal hormone, right? So you're gonna give them drugs that interfere with ACTH or adrenal hormone synthesis, drugs that suppress the adrenal function. However, we just did talk about your Addisonian crisis, right? Watch out for Addisonian crisis when we're giving or we're suppressing the adrenal function. Then we're gonna give or we're gonna do radiation therapy or surgery if it's caused by tumors. Nursing care, patient will be at risk for infection because of the increased cortisol, right? And we did talk about that when there's an increased cortisol, the immune system actually goes down. Now, if the immune system is down, your patient is at risk for infection. So we gotta make sure that we're preventing and monitoring infection. Fragile skin, we talked about those manifestations of Cushing syndrome. Altered body image, you see the truncal obesity and yet the extremity is thin and fragile. Personality changes is because of those hormonal imbalances going on. Nursing care of the adrenalectomy patient. Adrenalectomy is the removal of the adrenal gland. This is being performed if, like we said, maybe there's like a hypersecretion of the adrenal hormones, maybe being caused by an adrenal adenoma, like those tumors or carcinoma. So sometimes we have to remove the gland itself. The problem is that if you remove the gland, you're gonna have those manifestations and problems that goes with the decrease of these adrenal hormones. And we just did talk about those conditions and disorders when there's a decrease of the adrenal hormones. Your decreased cortisol and your decreased aldosterone. So that's going to be the problem, and that's going to be the thing that we're monitoring as nurses. Now, after the surgery, what's going to happen is this patient is going to have a replacement therapy. If it's just one adrenal gland that is removed, we call it unilateral adrenalectomy. And what we do is they require the replacement therapy for up to 2 years after the surgery. However, if it's a bilateral adrenalectomy, which means that both of the adrenal glands need to be removed, the patient will need lifelong replacement of both the glucocorticoids and the mineralocorticoids that we did talk about. Um, After that, what we're gonna do is we're gonna monitor and make sure that there's a follow-up again, that the tumor is not actually coming back. Pheochromocytoma, just really quick, this one is a benign tumor of the adrenal medulla. Right, you remember adrenal medulla? So this is your adrenal on top of the kidneys. This is the cortex, and this is the medulla. And This pheochromocytoma is a benign tumor of the adrenal medulla that causes excessive of those secretion catecholamine, those epinephrine and norepinephrine that is actually coming from the medulla. Let me write that down. Epinephrine and norepinephrine is actually from the adrenal medulla, right? So if there's a tumor in the adrenal medulla, there will be excessive secretion of those norepinephrine and epinephrine. So because of that, manifestation will be hypertension, hypermetabolism, and hyperglycemia. The episode is triggered by emotional distress, exercise, manipulation of the adrenal gland. Like I said, sometimes when they are trying to manipulate the tumor, then it could cause this oversecretion of the hormones of the glands. Postural changes, major trauma, including the surgery. And how do we treat pheochromocytoma? We treat it by surgical removal of the tumor. And that is chapter 40.